probably more than normal, but I just, I felt like it would be good information for you to have to go back to. And these scenarios are not in the virtual internship. So you won't be addressing them with your students, but you may be addressing these diagnoses, even though they're not this scenario. So keep that in mind. Okay. And I was just thinking of ways, Daniel and I were talking about organization the other day. Perhaps in a folder or some way, because you're also educators, and the other two will step up to education. I think, I'm not sure. But the thing about this is, if you have a congenital VSD, ventricular septal defect, and a student is asking you about that, where could you go back and find your information? Can you easily retrieve it from any of the education that we've talked about? And maybe just an alphabetic listing of the diagnoses that we talked about, and maybe an alphabetic listing of the procedures, or maybe the codes. Maybe that would be better. And I'm just brainstorming right here, just trying to think of ways to help you all down the road, because you're going to be stepping out pretty soon. We won't be doing these, I don't think, unless Leon tells me different. So I'm just trying to make sure that I'm covering everything that you're going to need.
Yeah, the plan is for us to use these video trainings to handle this, so that you don't have to do this in the future. Not that you don't enjoy it or do a great job at it, but it's not sustainable with large numbers of students. So,
right. And the thing that I will say to each of you right now is, I don't care who you're working for, you've got my email. Okay, so if you have a question, you've got my email.
Yay!
All right, Eugenia, that sounded too happy.
Yeah, I'm happy to hear that.
Listen, I'm not letting y'all go just because y'all get a job in the real world. That don't mean that we don't communicate. Okay, let's get that understood right now. No, I will always be here for all of you. Okay,
see, I'm jumping up.
Oh, Michael, okay. All right, guys. We have two more scenarios. Let's see, number 4. All right, let's look at these. Diagnosis: congenital ventricular septal defect. The procedure was a right and left cardiac catheterization for the congenital ventricular septal defect. All right, so coding, we nailed it. Q2 1.0, congenital ventricular septal defect. Code 935.96, if you look up cardiac cath for congenital cardiac defects, right and left, that is the correct code. But let's look, because it also has this little kicker right here that might have thrown one of us off, one or two of us off. Normal native connects, and then 935.97 is abnormal native connections. Now, unless you're working for a cardiologist, you won't see this a lot. You may forget it. So there again, it would be good to have this in a note somewhere of the VSD as congenital, and then the procedure codes. But let's talk about why 935.935. I'm doing ICD-10. 93596 is our correct code, because we need to understand what abnormal and normal native connections mean. So I did some homework. And by the way, these two codes are brand new for 2022. Okay. So there's a lot of information on these two codes out there on the web, an overabundance of information, but I tried to narrow it down so we could understand which code. And the bottom line here is that that physician's going to tell you if it's abnormal connections in his documentation. But we still want to understand it, because remember, when you're coding, don't just learn the code. To be a good coder and to grow with this career is to understand what you're coding, not just the number. It's very important that you have some basic understanding of your diagnosis and procedures. You're gonna grow in the career with that knowledge. Just assigning numbers won't get you too far. Okay. And then if you don't know, like I wasn't comfortable saying I know what normal connections are or abnormal connections are. You do your homework. You look it up. So that's what I did. Let's look at this. Normal native connections. Now this was actually taken from, oh, I wish I'd wrote it down, but I think I took it from Cincinnati Medical Center. I took it from physicians. Normal native connections. Blood flows along the expected course through the right and left heart chambers and the great vessels. They gave us examples. Acyanotic defects like coartication, VSD. That was the main thing. Ventricular septal defect. Those are normal connections. Having a ventricular septal defect does not mean that we have an abnormal connection. It just means that we have a defect in our heart, in the ventricle, okay? Abnormal native connections is alternative connections for the pathway of blood flow through the heart and great vessels. Most often we find that these are patients with cyanotic defects. So I want to sum this up. A small ventricular septal defect is usually minor. It has very few symptoms. However, the larger the hole, it might need to be repaired to avoid permanent damage and complications. When it's large enough, when that ventricular septal defect is large enough, or if there are more than one hole in your heart, it can cause problems with blood leaking between the two chambers instead of circulating through the heart in the correct order. When it's not treated in time, Eisenberger syndrome can develop, which means that some of the blood pumped to the body doesn't contain enough oxygen. So this results in the blood flowing in reverse direction. The physician documents the condition of abnormal native connections in his operative report, or could be both, his H&P. You will find documentation to support correct coding there. So without any evidence that we have any disease other than just the congenital ventricular septal defect, and they're doing a cath, a right and left cardiac cath, to visualize. What they're doing is trying to determine the extent of this ventricular septal defect, such as how large it is. Is it small? Is it going to heal on its own? Which sometimes they do. So our correct code is going to be 93596. I also wanted to look at 93457 and 93458, which was coded, and I wanted to help you understand why not to code these. This is a catheter placement in the coronary artery, but it's for a coronary angiography. Okay, so both of these are both the 57 is for the right and the 58 is for the left. This is actual viewing where they inject dye into the vessels for a angiography, a radiological exam, interventional radiology exam, and they do catheter placements in either the bypass graft or the internal mammary, wherever there are different areas, not in all of them, okay? and it includes an intra-procedural injection in order to capture the picture in the right heart, and the same thing in the left heart. So we would not code this as an angiography. All they did was a cath. And I did write this down because I wanted you to understand the cardiac cath, but I also use Mark manuals, and I use it. There's a professional edition, and I believe I don't pay for it. It's free. So I would think it's free to everyone. But if you look up www.markmanuals.com, it's an excellent resource. So it's here on this piece of paper too. But let's look at the definition of a cardiac cath. It's a thin catheter that's inserted into an artery or a vein in our neck, arm, or groin, upper thigh, through a puncture made with a needle. A local anesthetic is given to numb that insertion site. The catheter is then threaded through the major blood vessels into our heart chambers and into coronary arteries. It takes about 40 to 60 minutes. So it's not the extent of an angiography. And you can certainly YouTube these to really get a good visual of an angiography. An angiography is a catheter that's used to inject a radiopaque contrast agent into blood vessels so they can be seen on the x-rays. So I wanted you to see the difference in the procedures, but I'd mainly like to encourage you to look at on a YouTube and just pull up cardiac cath and look for a short video. Some of them are an hour long. Look for one that's about 10 or 15 minutes. It's just enough to let you see what that is, and then come down and look at your coronary angiography. Again, those may be 20, 30 minutes, but look at the difference in look at it and get it in your mind, the difference in it. But in the real world, this would be coded if you're working for a cardiologist. You will not code this, or if you're working for an ambulatory surgery center, you would potentially code this. But if you're working for a provider, it would have to be a cardiologist that does this procedure.
Yes, because the cardiology scenarios have not yet been updated, but it would be advisable to say this scenario is coming from a cardiology scenario. Will it be good?
Yes, and let me tell y'all, but not Daniel or Amara. This, if you know, the scenarios in our final exam would be the basic, such as this. Okay, you're not going to get the scenarios like are in our cardiology course, but what is today? Thursday. I believe it was Tuesday. Those should be available. Now, do you want to go and code those? You can, but that would be extra curriculum. I would advise you to focus on the other areas instead of cardiology at the point that all of you are at, unless we find out from Dave in the near future that you're going to be coding cardiology. I don't think so, but if you are, then we're going to bump in there and code those. Right now, we're going to get focused back on E&M. We're going to get through that. Those seem to be really easy for all of you. So our next weeks will be E&M. We want to get through with those because those were actually set up for us, this group, to get through. But we pulled away from that because you did so well. And I wanted to focus on areas that to get Daniel and Amara ready for the exam. Plus just to give us extra education on the areas that we could potentially be coding when we land that first job. But we're going back to E&M after today for a little bit. We want to get those finished. Okay. All right. So if you have anything in the final exam, it would be in this area, not as those in the cardiology course. We actually had someone that's a specialist in cardiology coding to reach out and do those for us. So I think he did an excellent job.